Good morning and welcome to the June Coding Corner education session. Today's session is going to be on diabetes coding tips. My name is Kristen Robinson. I have my CPC, CPMA, CCC, CRC, CEMC, and also I am a AAPC approved instructor. So this is just a little background about myself. And if you would like to reach out to me directly, feel free. So today's session is going to be over diabetes documentation best practices, combination codes as it relates to diabetes and other conditions throughout the body, as well as some additional codes that can be coded either with diabetes and these other codes. So we're going to start off with our documentation best practices. So some of the things you really need to consider whenever you are coding the documentation for diabetes. So make sure that there is a clear relationship documented between the condition and the manifestation. So you'll a lot of times in the provider's documentation, you'll see words like with, due to, associated with. If it is unrelated, they need to make sure they provide clarification in the documentation when they are unrelated. So, a lot of times, what this can happen with is there is causal or assumed relationships with diabetes. So, there is an assumed relationship with diabetes and peripheral neuropathy or polyneuropathy or with chronic kidney disease and some of these other conditions. So, unless your provider definitively tells you that these conditions are unrelated, you code them as related because there is an assumed or causal relationship. Okay, so you also want to make sure that you are educating your providers to not use words like possible, suspected, likely, because we need to know that these either are or are not related, and we need to know the definitive diagnosis. And you will see sometimes where the providers will say that they're trying to rule out or rule in a condition, but once that sign or symptom has been alleviated and now they have the definitive diagnosis, we no longer want to see these possible, suspected, or likely verbiage in the documentation. So we want to make sure that we're educating our providers to know when to drop the signs or symptoms and leave that definitive diagnosis. So we want to make sure that our providers are documenting to the highest level of specificity so we can assign the most appropriate ICD-10 code. So when I say the highest level of specificity, and a lot of times, as you know, providers will just say diabetes. They won't say type 1 or type 2. With diabetes specifically, the default is type 2. So if your provider's not telling you that this patient is a type 1 diabetic and all they're saying is diabetes, then by default we have to choose the E11.9. We want to educate our providers to document the specific type of diabetes and when it is related to other conditions because we need to be able to choose the most specific ICD-10 code. Okay. We also want to make sure that our providers are documenting what diagnoses are related to today's encounter, what conditions are affecting today's date of service, so we can accurately add the appropriate diagnosis codes to that claim. There is sometimes where a patient may have an entire laundry list of diagnosis codes, but we need to know what is being addressed and treated on today's encounter. Also, we need to make sure that the providers are documenting these chronic conditions, and when they are seeing these patients, they are being addressed at least once per year. As you may know, some patients have a higher morbidity or mortality due to comorbid conditions. So, in that case, they may be seen more than once a year. They may be seen every 6 months, every 3 months, or if it's more serious, they may be brought back within a few weeks if a new medication is introduced or a change in dosage is introduced. So we need to make sure that these chronic conditions are being addressed at least once per year. For the purposes of HCC coding, for any of you that might be listening to this recording, or if you're on the live today and you do risk adjustment coding or hierarchical condition coding, you know that it must meet the MEAT, MEAT standard. That's monitor, evaluate, assess, and treat. So they may list this laundry list of diagnoses, but what are they actually assessing and treating on today's encounter? Also, we want to make sure that our providers are signing and, in some cases, doing the appropriate attestations when they are using, say, for instance, incident to guidelines, split shared guidelines, or simply signing the record. We need to make sure that we see the provider's credentials. We know that this is the correct data service and they're using the correct patient identifiers. So, a little bit more specifically about diabetes documentation. So, specifically with diabetes, just like I mentioned earlier, we need to know the type of diabetes and we need to know those related conditions. We need to know, how is this provider treating this diabetes? Are they treating it with an oral medication? Are they treating it with an insulin? Are they treating it with an injectable insulin? These are all things that we need to know because they affect the diagnosis codes that we ultimately choose as coders, because there are specific Z codes for non-insulin insulin injectables, and by mouth diabetic drugs. Also, as we mentioned earlier, the difference between type 1 and type 2 diabetes. There's also secondary diabetes and diabetes that's been caused by other conditions, to a lesser extent, but still apply because there are scenarios where it isn't just type 1 or type 2 diabetes. And again, if it is not documented the type of diabetes, you need to make sure that you know that the default type is type 2. Again, the causal link between diabetes and other conditions, and we're going to discuss that on some of the further slides. Remember that if diabetes is documented with complications, we use the higher specificity diagnosis codes. If it is diabetes without complications, whether the doctor says diabetes with no other information at all, which we would use the E11.9, but if there is complications, if there are issues or other conditions due to the diabetes, E11.9 is not appropriate. So this is just a nice visual of some of the diabetic complications that we see within this documentation. So you may see diabetic complications from heart attack, stroke, diabetic retinopathy. You see a lot if you're in cardiology or if you're in vascular coding, the relationship between diabetes and peripheral artery disease, nephropathy, neuropathy, and especially diabetic foot conditions. A lot of times you'll see that there is a direct linkage between like long-term sores or um, other conditions such as amputation of toes, amputation of the entire foot, or even the lower leg or up to the knee due to complications from diabetes directly. So now we're going to talk a little bit further about diabetes and this causal link between diabetes and other conditions. As you can see, or you may already know, there is a huge list of conditions that have a causal link to diabetes. So I'm not going to list all these out individually, but as you can see from this slide, there are so many conditions that have a causal relationship with diabetes. So now we're going to get into what are some of the most common combination codes with diabetes. So, some of the things to consider: diabetes without complications. When it tells us that the is type 1 without complications, that's going to be our E10.9. Type 2 without complications is our E11.9. And you need to know when to use the combination codes when there is a complication due to diabetes. So let's talk about diabetic nephropathy. Okay, so we have type 1, which is E10.21, and then we have type 2, which is E11.21. And you'll see this consistently throughout the entire section of the diabetes chapter, that whatever the type 1 version is, it will mimic the type 2 version. So if it's E10.21, the same condition for type 2 is going to be 0.21. Remember that we have this causal relationship, which means that there is a presumed relationship between diabetes and nephropathy, unless the provider directly documents that the conditions are unrelated. But 99% of the time, these conditions are in fact related or due to the diabetes, and will always be coded as a combination code, and then it will give you the parameters between the code also. So once you get out of your alphabetic index and you get into the tabular section and you get to that code, say for instance the E11.21, if it tells you to code also the second condition, which in this case would be the nephropathy, you would want to make sure that you also bill the nephropathy code secondary to the combination code. Okay, so for instance, it says code diabetic chronic kidney disease when both the diabetic nephropathy and the chronic kidney disease are documented, as the chronic kidney disease is more specific than the neuropathy. So hopefully that makes sense. So let's talk a little bit more about diabetic chronic kidney disease. So again, there is a direct causal relationship between chronic kidney disease and diabetes. So when you see in the documentation diabetes with chronic kidney disease or chronic kidney disease due to diabetes, those are those call out words that tell you the provider is telling you these two conditions are in fact related. So when you have these conditions, you have a use additional code direction in the ICD-10 book that tells you to code your E11.22 or your E10.22 for the diabetic chronic kidney disease. And then you will also use the code for the appropriate stage of chronic kidney disease. So if you're already into coding, you already know that there are 6 stages of chronic kidney disease. So you have your category code is your N18, and then your subcategory is that additional digit that tells you what stage the chronic kidney disease is in. So for instance, N18.1 is stage 1 or point 0.2 is stage 2. With stage 3, you have 3.0 and 3.1 and 3.2, and that is N18.30 is unspecified, stage 3, 3.1 is 3A, and then 3.2 is 3B. And then you have stage 4, 5, and then end stage renal disease is your N18.6. So remember, you code your diabetes combination code first, followed by the N18 code for the stage of chronic kidney disease. Now, there is also a causal relationship when you have hypertension with chronic kidney disease and you have diabetes. So, specifically, when you have diabetes, chronic kidney disease, and hypertension, you have to sequence them appropriately. So, when it says that you have chronic kidney disease with diabetes, that's your E10 or your E11.22, then you're going to use the appropriate hypertension code, which in this case, if you only had diabetes, chronic kidney disease, and hypertension, then you would have the I12. Your I13 is when you have hypertension, chronic kidney disease, and congestive heart failure, which is a whole nother category for the hypertension code, which we will not be getting into at that um, detail today, but just know that it's based on sequencing of the diabetes and the chronic kidney disease, as well as the hypertension, which also has a causal relationship with chronic kidney disease. So another common combination code that we see is the ophthalmic conditions or complications. So that might be retinopathy, that could be with or without macular edema. This could be with cataracts or some other complications that are affected in the eye. So again, just like we discussed with our um, chronic kidney disease with diabetes, you have your type 1 and your type 2. And then in this case, your subcategory is your point 0.3, followed by your last digit based on what the complication is. So again, you have your causal relationship between the diabetes unless the doctor specifically says the condition is unrelated. So, for instance, when you're coding diabetic retinopathy, you have your E1 and then you have your 0 if it's type 1, your 1 if it's type 2, point 0.3, and then it will tell you to include the proliferative or non-proliferative laterality and the stage. With cataracts, it can be described as cortical, nuclear, and posterior subscapular and nuclear sclerotic. That's what prompts that additional digit to give you the specific cataract code. So now we have our complication of a neurological complication or neuropathy. There are different types of neuropathy, polyneuropathy, as one of the options you have. So again, when you're talking about combination codes, you're always going to have your E10 or your E11. And just like I mentioned with the previous complication, now your subcategory is your point 0.4 followed by your additional digit based on um, uh, the type it is. So you have a causal relationship unless it's documented otherwise, and then you report the combination code for the diabetes and the neuropathy when separately reported. So with diabetic peripheral angiopathy, this can be with or without gangrene. So, as we know, if you are used to coding diabetes, you will see this a lot with advanced stages that people that either have uncontrolled diabetes with other conditions or advanced diabetes with other conditions, sometimes you will see this be documented with gangrene, and it can be through different layers of the skin, and it can be all the way to the bone if it's advanced into the end stages. And when it's gotten to the bone, a lot of times um, the provider will make the decision to amputate because at this point, the treatment is beyond repair. So that means that it may be an amputation of a toe, it could be an amputation of all of the foot, part of the foot, and typically up to the knee, depending on the severity of the stage of the diabetes with the gangrene. So, specifically with your peripheral angiopathy, again, you have your E10 or your E11, and then in this case, you'll have your 51 or your 52, depending on if it's with or without gangrene. Okay, so as you know already, we have the causal relationship. So, with peripheral arteriosclerosis, peripheral vascular disease, and other peripheral arterial diseases with a diabetic patient, they should be linked and coded as diabetic peripheral angiopathy. So, when you see these documented, you need to know that it is coded as peripheral angiopathy. So, with carotid artery atherosclerosis, it is also considered a peripheral atherosclerosis. So, remember, you have that causal relationship and you see how your provider is documenting these related conditions, and you have to make sure you choose the appropriate subcategory and additional digits as appropriate. So, for a complication of a foot ulcer or a sore, there's also a direct causal relationship, and there's also a code also note. So once you get out of your alphabetic index and you see that this is a diabetic foot ulcer, and you know that it's either E10621 or E11621, you also have to know more about the foot ulcer itself. So they'll give you the site of the ulcer, and sometimes they'll also give you the stage of the ulcer. So we know that there is a code also note that says to identify the site of the ulcer. So that's going to be your L97.4 or your L97.5 codes. So you already know that you're going to have a second code when it is documented appropriately for you to code to the high specificity. You need to know that it's diabetes with a foot ulcer, and you need to know where is that foot ulcer. Okay. Ulcers located on the foot are assumed to be related, but when the ulcer is in another area of the body, it is not assumed. We have to have that confirmation from the provider's documentation. So just remember that when you see foot ulcers, it's assumed, but if it's an ulcer in a different location of the body, say for instance, um, one that's on the sacral area, for instance, it is not assumed. Your provider has to tell you that it is related to the diabetes for you to code as such. So one of the very most common that we see this very often, is diabetes with hyperglycemia. So basically, hyperglycemia is that the glucose level is increased. So they may be doing an A1C, they may be just running glucose numbers, and they see that the glucose numbers are elevated. So your provider is going to document this is diabetes with hyperglycemia, and it's always going to be the 6-5. So whether it's type 1 or type 2, you have your subcategory, and your fifth digit is going to be a 6 and a 5. So again, we have this causal relationship, and I honestly have never seen where a patient has a history of diabetes with hyperglycemia where you would not document these as related. I have never seen it. So I would say that that consideration would be very rare, that you would ever see um, a patient that has an established diabetes diagnosis where the hyperglycemia is not directly due to the diabetes. Also, remember that if your provider documents uncontrolled diabetes or controlled diabetes, those are what we call non-essential modifiers. So if you look up that code in the book, you look up diabetes and you're looking for uncontrolled, it's going to be in parentheses with the word diabetes, and it does not change the actual code assignment. If you see uncontrolled or controlled diabetes, it's still just E11.9 for type 2. Okay, there is no additional digits for controlled or uncontrolled. When you do have the additional digits is when you have hyperglycemia or hypoglycemia. So, as I just stated, hyperglycemia is when the glucose level is elevated, whereas hypoglycemia is when the glucose numbers are lower than normal or below where the goal is for that particular patient. So, when hyperglycemia is poorly controlled, inadequately controlled, or out of controlled, diabetes with hyperglycemia should be coded. So, when they tell you these specific call out words, if your provider says diabetes with hyperglycemia poorly controlled, we know that that's still E11.65. Okay. But you have to have the support for it to be coded with hyperglycemia. So now let's talk a little bit about the sign and symptom. So sometimes your provider will say that this patient is pre-diabetic, or they have borderline diabetes, or they're having um, higher than normal glucose readings. So if there is not a definitive diagnosis of diabetes or a history of the chronic condition of diabetes, if they are having increased um, glucose readings, or your provider documents it as prediabetes or borderline diabetes, we would not use the E code series or the E code category. You would use your sign or symptom code R73.03. So, with simply just an elevated blood sugar or any other like non-definitive diabetes diagnosis, we would use our sign or symptom code. But just remember that if borderline or pre-diabetics are left untreated for a long period of time, it can in fact turn into type 2 diabetes. So basically what they say is that if it's left untreated, that it progresses to type 2 diabetes within or less than 10 years. So this could be in patients that are not showing active signs or symptoms. You can have an increased blood sugar and not be having any signs or symptoms. And the only way that you or your provider would know is if a blood glucose reading is done or an A1C is done. Now, some of the symptoms that may be seen might be frequent urination or dry mouth or excessive thirst. Those are some of the very first signs that a patient is, in fact, pre diabetic or already a diabetic. They may come to their provider with, they may just be saying, I've been really thirsty recently. I've been drinking a lot more water, or I've been using the restroom much more frequently than I normally would. So they may do some other testing like, a UA or some other blood work like a CBC or something like that. But ultimately, if you have some of these signs or symptoms, they're going to do a glucose reading or an A1C. So a glucose reading is more of an immediate result, whereas an A1C looks at a defined time period and gets a median number. So, some of the other additional codes that we need to consider with diabetes is, as I mentioned earlier, if your provider tells you in the documentation that they're on a oral hypoglycemic drug, or they're on a insulin injectable or a non-insulin injectable drug, there are Z status codes that we use to further explain the patient's situation. So when you're adding these Z79 codes, because all of these drug codes, so if a patient is on long-term insulin or a long-term oral hypoglycemic drug or any of the other drug categories like NSAIDs, anticoagulants, aspirin, all of these are Z79 category codes, and your additional subcategory and additional digits further clarify the type of drug, or the kind of drug it is. So you also have some situations where a patient is on both an insulin drug and a non-insulin based drug for an anti-diabetic drug treatment. So basically, if they document both, you can bill both. So if the provider documents that this patient is on a non-insulin drug and an insulin drug, you can use both of the Z79 category codes as appropriate based on the documentation. So again, if they are being treated with both an oral hypoglycemic drug and an insulin, the appropriate codes would be your Z79.84 and then your Z79.4 as the appropriate documentation states. We also have, and typically this is only seen in type 1 diabetics. There are, I guess, rare cases where there might be an insulin pump for a type 2, but that would be, in my opinion, very rare. Typically, with insulin pumps, that is for type 1 diabetics because most type 1 diabetics are born with type 1 diabetes. That's why back in the day, you would hear type 1 diabetes referenced to juvenile diabetes. That was the term that was most coined, that juvenile diabetes is type 1 diabetes because typically patients are born with it or it develops early in childhood. Well, they've kind of stopped using that term because, as we all know, in the past, say, 10 to 20 years, type 2 diabetes has become very prevalent in children and young adults because of the eating habits that Americans have nowadays. We have a higher level of both diabetes and obesity in children, where it's not as typical to see a juvenile patient with just type 1 diabetes. Now it's ever growing that type 2 diabetes is more prevalent in children. So they don't normally use juvenile to specifically um, call out type 1 diabetes. But that being said, getting back to this slide, insulin pump usage is typically for type 1 diabetics. And if you see it documented, you want to use your Z96.41, which is different than your Z79s because it's not specific to a drug, it's the use of the insulin pump itself. So the resources for today's presentation is the Optum ICD-10 Expert 2025, and I also drew some of this information directly from the Risk Adjustment Documentation and Coding book put out by Poe Bernard. So I hope that everyone really enjoyed today's presentation. For those of you that are watching this on replay on YouTube, I would greatly appreciate for you to hit that notification bell and subscribe to the page. If you are not already part of the Coding Corner on Facebook, I would love for you all to jump over there and also follow us over there. I am also on LinkedIn for any of you that would like to link up over there. So I hope everyone has a good rest of your day, and thank you again for tuning in.